Hello, so my name is Jean-Marie Péron. I'm from Toulouse, France. I'm a hepatologist, and I'll have the pleasure of talking about the current management of hepatitis E. I would like to thank Patrick Marcelin and his team for the invitation once again. So these are the main points I will be talking about. This is all you need to know. Diagnosis of hepatitis E relies on serology and/or nucleic acid testing. Neurological disorders are frequent with hepatitis E infection. The risk of severe disease is enhanced by underlying cirrhosis. Chronic infection in immunosuppressed patients is treated with ribavirin. Treatment of acute infection with ribavirin may be considered in some patients, including cirrhotic patients, older patients, patients with neurological injury. And I'll have a little data on prevention also. So this is the most recent data on epidemiology of HEV. As you know, it's the leading cause of acute hepatitis worldwide, but also in Europe and in France. It's over 20 million cases per year, 3.3 million symptomatic cases, 44,000 deaths per year. In Europe, it's 2 million cases per year. And in France, these are the latest numbers. 2,600 cases were diagnosed in 2019, 97% of which were autochthonous. HEV is part of the Hepaviridae family. And interestingly, you can see unenveloped virion in the stools, but quasi-enveloped virions circulate in the blood. So this is a particular of this virus. Strains which infect humans belong to the orthoepivirus genus, mostly A, but also C. There are 8 genotypes and 31 subtypes. I'll be talking about some of these genotypes during this talk. This is the worldwide distribution of HEV. As you can see, genotype 1 is seen mostly in Africa and Asia. Genotype 2, which was seen initially in Mexico, is also seen in Africa. And genotype 3 is the prominent genotype in Europe, North America, South America, Japan. Genotype 4 can be seen, but more rarely in Europe, and mostly seen in Southeast Asia. This is data on the seroprevalence of HEV. And as you can see, it varies greatly worldwide. You have some hotspots here in Asia, in particular Nepal and Tibet. And you have around between 10% and 30% seroprevalence in Europe, and a little bit less, 10% in the United States. But what's interesting is that if you go and you look what's going on in one country, for example, France, you can see that this is a study on blood donors. So we tested IgG seroprevalence in blood donors, and you can see that the mean IgG seroprevalence is 22% in France. But actually, it varies from 8%, Haute-Loire, which is here, to 86%, which is really a hot spot in Ariège, close to where I live here. So you have great diversity in the seroprevalence, even within a single country. This figure shows the number of cases of HEV diagnosed in France. As you can see, it's a significant increase in HEV diagnosis from 2004 to 2016, and I have the latest numbers in 2019. Most of these cases are autochthonous. As you can see, in 2019, we had 2,600 cases, of which 26 were imported. That's about 3%. And the numbers of important cases are not increasing, and it's the number of autochthonous cases which are increasing. The clinical outcome is different according to genotypes. On this table, I'll be comparing genotypes 1 and 2 to genotypes 3 and 4. The source of infection for genotypes 1 and 2 is an obligate human pathogen. When it's zoonotic for HEV 3 and 4, there's a risk also of transmission via blood supply. The route of infection for genotypes 1 and 2 is fecal-oral via infected water. And for 3 and 4, it's the consumption of infected meat, in particular pork. There are huge outbreaks for HEV 1 and 2, and there are no outbreaks for HEV 3 and 4. The clinical attack rate is also different, 1 in 5 for HEV 1 and 2, 1 in 10, less than 1 in 10 for HEV 3 and 4. HEV 1 and 2 mainly affects young adults, when HEV 3 and 4 mainly affects older men, with a male-female ratio of 3 to 1. There is never any chronic infection with genotypes 1 and 2, when you can have chronic infections in genotypes 3 and 4, but only in immunosuppressed individuals. All genotypes, with all genotypes, you can have occurrence of a second HEV infection, which is very important. And also all genotypes can induce neurological injury and therefore neurological sequelae. So seroprevalence is high, and as you've seen, very high in some regions. Incidence is rising, and most cases still go unnoticed. I'll be talking about transmissions for the next few slides. First, genotypes 3 and 4. HEV infection is a zoonosis with these genotypes with an animal reservoir, which is mainly domestic pigs. Other animals have been found to be infected with HEV, including rabbits, for example. A new zoonosis, a new animal reservoir has recently been described. It's the camel with genotype 7, and there are case reports of infection of patients with HEV from the camel. It's either eating camel meat or drinking camel milk. So that's a risk of infection and chronic hepatitis if the patient, for example, is a transplant patient. The seroprevalence in camels is very high, 68%, as you can see, and the seroprevalence in people that take care of camels or are in contact with camels are 21%. So I think in Middle Eastern countries, this is a risk of transmission that is an important risk. At least it's important to know. Genotype 7. The newest genotype is actually the species Orthoepivirus C, HEV C1. So this is very interesting because this is data that's been published in the last few years. And Orthoepivirus C is genetically very divergent from Orthoepivirus A. So these are viruses that are not very similar, and you can still have zoonosis with HEV C1. The transmission is from rat to human, and it's mainly been described in Hong Kong. So there is a risk of transmission of HEV from rats to humans, especially if they are immunocompromised. There's a risk of transmission via transfusion. It's been described with genotype 3, but actually, obviously, it can be seen with all genotypes. This is a paper from England where 225,000 blood donations were tested, and you can see that 1 in 2,848 donors were viremic with the risk of contamination of patients. So there is a risk of transmission of HAV with transfusion. And this is data from Germany, the Netherlands, France, showing a risk of donor viremia going from 1 in 762 in the Netherlands to 1 in 1,240 in Germany. It's a lot less in the United States. So there's a risk of transmission of HEV via transfusion. So as we've seen up to now, HEV infection can be a zoonosis. There's more and more data on this risk of transmission. There's also a risk of transmission with blood transfusion. Blood donations, in fact, are already screened in different European countries and in the UK. And in France, HEV is detected in plasma donations. So what about the clinical aspects? I'll focus on HEV 3 and 4. As I've told you, it affects mainly older adults. The incubation is 40 days, and most patients will not have symptoms. So asymptomatic infections are the rule, but some patients will have clinical symptoms. And in this case, the prodromic phase is 3 to 7 days, and you can have jaundice in about 40% that will last 1 to 2 or 4 weeks. There are no chronic hepatitis in immunocompetent patients, but you can have severe or fulminant hepatitis in immunocompetent patients, with a mortality which is high from 0.5 to 4%, especially in elderly patients and in patients with cirrhosis. Interestingly, it's the hepatitis virus that causes the most neurological symptoms, with the risk of neurological symptoms that ranges around 15%. This table describes clinical characteristics from patients in France, published recently. This is interesting because we studied 137 consecutive patients, and you can see that the age is mean 53, mostly males, 74% hospitalizations, which is very high. So this means that when HEV is symptomatic, usually it's a severe infection. You have asthenia in 85%, jaundice 43%, and in this study where patients were prospectively studied, the risk of neurological injury is high. It's 16.5%. When your patient has elevated transaminases, if you're at the beginning of the infection in the first few weeks, you should be able to diagnose HEV by PCR in the stools or in the blood. As you can see, HEV stays in the stool for a longer time than in the blood, so it's good to do both if you can. And you can also do a serology and test for IgM and IgG, which should be positive when your patient has elevated transaminases. So the guidelines, the EASL guidelines for the diagnosis of HEV for the diagnosis for HEV in patients with elevated liver enzymes, if they're immunocompetent, the gold standard is to do serology and PCR testing. But if you have no access to PCR testing, the serology is very useful. In immunocompromised patients, then you have to do PCR testing because you often have negative serology is often falsely negative. Now, let's talk a little bit about the neurological disorders. First thing is that the cases have been described worldwide. So this is a possibility with all genotypes. Second important fact is that usually the liver symptoms are mild. Jaundice is almost never present. So this is mostly a neurological thing with sometimes elevated liver enzymes. And you can see that you have a lot of different types of neurological symptoms, including meningoencephalitis, neuralgic amyotrophy, GBS, for example, and mononeuritis multiplex, all kinds of neurological symptoms. And this was a French study we did, studied 14 patients. And as you see, we have 4 main entities that were described. And in particular, mononeuritis, neuralgic amyotrophy, meningoencephalitis, and GBS. Neuralgic amyotrophy is caused by HEV in around 10% of the cases. So HEV is an important etiology for neuralgic amyotrophy. And this study is interesting because it's a big study. It's a multicentric study, 11 centers, 7 countries, and we compared 57 cases of neuralgic amyotrophy with HEV to 61 cases without HEV. And as you can see, the main differences are that when you have an HEV infection, you have more often damage outside the brachial plexus, and you have more often sensory symptoms. So now let's talk a little bit about patients with cirrhosis. And this is an older paper, but one of the earliest papers showing the risk of HEV infection in patients with cirrhosis. In this paper, we compared the severe form, meaning patients with encephalopathy, to the mild form, meaning patients with no encephalopathy. As you can see, patients with the severe form were older, even though it was not statistically significant. They had more alcohol abuse, and very importantly, they had more often cirrhosis, with a mortality which was very high, around 71%. And this data has been confirmed in multiple studies worldwide. And this is one of the more recent papers from Taiwan, very interesting paper studying the risk of HEV superinfection in patients with HBV cirrhosis. And if you look at these patients, this is the risk of HEV superinfection in patients with cirrhosis compared to patients without cirrhosis. And the top line is the cumulative incidence of liver-related deaths. So HEV superinfection augments the risk of death. And this is another way to look at the data. You have patients with cirrhosis, patients without HEV exposure on the bottom, and patients with HEV exposure on top. You can see that the mortality is higher with patients with HEV exposure. So it's dangerous for patients with cirrhosis to have HEV superinfection. Now let's talk about treatment. First, I'll talk about treatment in immunosuppressed patients because there's more data. As you know, HEV infection can be chronic and lead to cirrhosis in immunosuppressed patients. This is very well-known data. And different case reports and small articles showed that ribavirin was the treatment of choice. And this is really the biggest paper from all the transplant centers in France studying ribavirin for 3 months in the treatment of chronic hepatitis E. And as you can see, you had up to 80% sustained virologic response, which means patients were cleared and were cured of HEV infection when you do a 3 months regimen of ribavirin. And if the patients that had a recurrence were treated 6 months, and then you have 90% sustained virologic response. So ribavirin has very strong efficacy in the treatment of chronic hepatitis E. Unfortunately, some people relapse, or some patients will have resistance to ribavirin. And in these patients, you should try peg interferon. Now, you have to be very careful, especially in transplant patients, especially in renal transplant patients, because peg interferon can induce acute rejection. So you have to be really careful. But this paper here is from Caen in France, and they very nicely showed that in a patient with renal transplant, ribavirin had not good efficacy. They added interferon, and they obtained undetectable HEV, curing the patient. So if you're very careful, you can treat these patients with the combination ribavirin and interferon. So treatment of chronic hepatitis E is a 3 months ribavirin regimen. In case of relapse, you need to treat patient for 6 months. And if ribavirin is not sufficient, then you can add interferon in very selected patients. These are the guidelines from the EASL. Importantly, the risk factors for relapse, I think there's one risk factor that you need to know. It's the presence of HEV RNA in the stool at the end of treatment. If you have HEV RNA in the stool after 3 months of treatment, you need to go for 3 more months. So 6 months total. Now, what about acute hepatitis C? There's less data, but we had this French study we did treating 21 patients with ribavirin. This was acute hepatitis E with elevated transaminases. Patients were treated because they had severe hepatitis or were older patients. And some patients had immunosuppressants with an acute hepatitis E. And the treatment here recommended is ribavirin à la carte, as we would say in France, which means that you stop treatment when the virus is cleared, and you do HEV testing every week with PCR, and you check for the viral load. So we showed that the treatment was well tolerated, and HEV was undetectable in a median of 29 days. So this is a proof of concept study. It does not confirm that you should treat patients with HEV with an acute HEV infection. What about prevention? Well, there's two different, I think you have 2 different types of prevention. For HEV 1 and 2, the aim is to provide clean drinking water and to improve sanitary infrastructures in the developing countries that need improvement. And for HEV 3 and 4 infection, it's totally different, obviously. You need to tell your patients to avoid eating undercooked meat, especially pork products, and especially if they're cirrhotic, or they have cirrhosis, or if they have a liver transplant or immunosuppressed. In China, you have a vaccine which has a very high efficacy. The data is on HEV4. There's limited data on HEV1, and there's no data on HEV2 and 3. But this vaccine should have a strong efficacy, whatever the genotype. I don't think genotype matters for this vaccine. So hopefully we'll have it someday in Europe and in the rest of the world. So in conclusion, When should you look for HEV? I'll be basing on the EASL guidelines, obviously. If you have a patient with acute viral hepatitis, you need to check for HEV as a first-line workup. If you have a patient with suspected drug-induced liver injury, this is a chapter I did not have time to talk about, but you need to test for HEV infection. If you have a patient with decompensated cirrhosis, especially if he has jaundice, then you check for HEV. If you have neurological symptoms, even if it's just not one of those typical neurological symptoms, but if you have acute neurological symptoms with elevated transaminases, then you need to check for HEV. And obviously, if you have elevated transaminases after transfusion, then you need to check for HEV. So how do you diagnose HEV infection? If you can, you do the gold standard. In immunocompetent patient, you do serology and PCR. And if you can, you do PCR in the blood and in the stools. If you only have access to serology, it's fine. It's a good way to diagnose acute hepatitis E. If your patient is immunosuppressed, you need to check for PCR, and the best is to do it in the stool and in the blood. Treatment of acute hepatitis E is ribavirin monotherapy. Patients with severe acute hepatitis E may be considered. So these are the EASL guidelines, may be considered. Patients with neurological injury may be considered, and patients with acute hepatitis E and underlying cirrhosis may be considered. If you want my opinion, what we do in Toulouse is these three types of patients, we treat them with ribavirin. Treatment of chronic hepatitis E, the data is stronger. First, you need to reduce immunosuppressive drugs. Then you go for 3 months of ribavirin. You check for PCR, HEV PCR in the stools at M3, and you go for 3 more months if the PCR is positive. You go for 6 months in case of failure of 3 months regimen. And in patients who fail interferon therapy, then you can add ribavirin. In selected patients, you need to be very careful for acute graft rejection. Thank you very much. Thank you for listening to me. I'd like to thank my friends and colleagues in the hepatology unit, in the transplant unit, Nassim Kamar, who did all the work on the chronic patients, the virology unit from Florence Abravanel and Jacques Isopé, and our neurologic specialist, Pascal Sintas. Thank you very much.